If your doctor told you that you have a fatty liver, grade 1, mild, watch your diet, come back in 6 months, and you walked out of that appointment not entirely sure what you had just been told, this video is for you. Because what you were told is technically accurate and practically incomplete. A fatty liver result is not a liver problem. It is a metabolic signal, one of the clearest and most actionable signals your body can produce, that something systemic has been building quietly for years. And the 6-month follow-up approach, while standard, leaves most people without the one thing that would actually change their outcome, a clear understanding of what is driving it and what reverses it. Today we are going to cover both. The mechanism behind fatty liver, specifically why it develops in people who eat reasonably well and do not drink heavily. The signs your body may already be sending you beyond the ultrasound result, and the specific, evidence-based changes that reduce liver fat, not as vague lifestyle advice, but as targeted actions with understood mechanisms, what the liver actually does, and why fatty liver is a systemic signal. The liver is commonly described as the body's filter. That description undersells what it actually does by a significant margin. Your liver manages glucose storage and release, deciding at any given moment whether to absorb excess glucose from the blood or release stored glucose when levels drop. It controls how dietary fat is processed and transported. It produces bile, without which fat digestion cannot occur. It breaks down hormones after they have completed their function. It regulates cholesterol synthesis and clearance. It processes every medication you take, every compound that enters your bloodstream, and nearly every metabolic byproduct your cells produce. This is not background work. It is central, continuous, and affects every system in the body. When fat accumulates inside liver cells, a condition called hepatic steatosis, this entire operation becomes progressively harder. And here is the critical point most people never fully absorb. In the majority of people who develop fatty liver without heavy alcohol use, the fat is not there because of dietary fat intake. It is there because of a process called de novo lipogenesis, the liver converting excess glucose and fructose into fat when insulin resistance has disrupted normal glucose metabolism. Insulin resistance means the body's cells have become less responsive to insulin's signal to absorb glucose from the bloodstream. The pancreas compensates by producing more insulin. The liver, exposed to chronically elevated insulin and excess carbohydrate substrate, shifts toward fat production. That fat accumulates inside liver cells. This is what shows up on an ultrasound as fatty liver. This is why addressing fatty liver requires understanding insulin resistance, because treating one without understanding the other produces incomplete results. Why the liver stays silent, and why that makes early diagnosis important. The liver has almost no pain receptors. This is not a metaphor, it is anatomy. Unlike the stomach, which signals discomfort almost immediately when something is wrong, the liver can be under significant metabolic pressure for years, accumulating fat, developing early inflammation, and produce no sensation you would recognize as a warning. Some people notice a vague fullness or mild pressure beneath the right rib cage, not pain exactly, more like a persistent awareness that something is there. Many people feel nothing at all. This silence does not mean absence of progression. Fatty liver in its early stages, what is classified as simple steatosis, is reversible. The liver has one of the strongest regenerative capacities of any organ in the human body, but left without intervention, simple steatosis can progress to steatohepatitis, where inflammation joins the fat accumulation. Steatohepatitis can progress to fibrosis, structural scarring, and fibrosis, if it advances to cirrhosis, represents damage that does not reverse. The distinction between NAFLD, non-alcoholic fatty liver disease, the fat accumulation phase, and NASH, non-alcoholic steatohepatitis, where inflammation has developed, is one of the most clinically important in liver medicine. A grade 1 ultrasound result almost certainly represents the early NAFLD stage. The presence of inflammation, which is what drives progression to fibrosis, is not detectable on a standard ultrasound. It requires blood markers, specifically ALT and AST enzyme levels, and in some cases a fibroscan or liver biopsy, to characterize fully. This is why mild, come back in 6 months is medically reasonable as a monitoring approach, but insufficient as a management strategy. The early phase is the window of highest reversibility. Acting during that window produces meaningfully different outcomes than acting after inflammation has taken hold. The signs appearing outside the liver: your body is producing signals beyond the ultrasound finding. Understanding them matters because they clarify how widespread the metabolic process has become. Fatigue that does not fully resolve with sleep. The liver's role in glucose metabolism and energy regulation means that when it is under strain, the downstream effect on cellular energy is real. This fatigue is characteristically different from tiredness. It tends to persist through the day, rather than improving after rest, and it often peaks in the mid-afternoon. Central fat accumulation. Fat that gathers around the abdomen, specifically the visceral fat surrounding the organs, is metabolically active. It releases inflammatory compounds and worsens insulin resistance in a cycle that feeds directly back to the liver. Central fat accumulation is both a consequence of insulin resistance and a driver of it. Elevated triglycerides, low HDL, and borderline fasting glucose. These 3 laboratory findings, when they appear together with a fatty liver finding on ultrasound, are not 4 separate problems. They are 4 expressions of the same underlying process. Metabolic syndrome driven by insulin resistance. Research consistently shows these findings cluster together. If you have one, the others are worth specifically checking. A visible skin sign that is frequently missed or misattributed. Acanthosis nigricans. This is a darkening of the skin, often described as having a velvety texture, that appears in skin folds and areas of friction, the back of the neck, the armpits, the inner elbows, the groin. It is not caused by sun exposure or inadequate hygiene. It is caused by chronically elevated insulin levels stimulating a receptor in the skin that produces excess skin cells in these areas. Acanthosis nigricans is one of the most reliable external markers of insulin resistance. Many people have been told it is simply pigmentation, or have never been told anything about it at all. In the context of the other findings discussed here, it is a meaningful clinical signal that the insulin resistance driving fatty liver has been present and significant for some time. What actually reverses fatty liver, the mechanism, not just the advice. The standard advice, eat less fat, lose weight, reduce alcohol, is not wrong, it is incomplete. When you understand the mechanism, the specific changes that move the needle become clear. The primary target is reducing de novo lipogenesis, the liver's conversion of excess glucose and fructose into fat. This requires reducing the substrate that drives that process and improving the insulin sensitivity that determines how that substrate is handled. The fastest single lever, reduce liquid fructose. Fructose is metabolized almost exclusively in the liver. Unlike glucose, which can be absorbed and used by muscle, brain, and virtually every other cell in the body, fructose travels directly to the liver and is processed there. In large amounts, particularly the amounts present in sweetened beverages, the liver converts the excess fructose into fat through de novo lipogenesis. This is not a pathological response. It is the liver doing exactly what it is designed to do with the substrate it is receiving. The problem is the quantity and the frequency, the sources most people do not fully account for. Fruit juice, commercial smoothies, flavored waters, sweetened teas, commercial coffees, and yes, soda. A glass of orange juice delivers concentrated fructose without the fiber present in the whole fruit that slows absorption. Removing or dramatically reducing sweetened beverages is the fastest dietary change with the most direct effect on liver fat. Research shows this produces measurable reductions in liver fat within weeks. The second major dietary driver, refined carbohydrates that chronically elevate blood sugar and insulin. White bread, packaged crackers, breakfast cereals, instant noodles, pastries. These foods spike glucose rapidly, maintain the insulin elevation that drives fat production, and provide little of the fiber, protein, or micronutrients the liver needs to repair itself. Replacing these with foods that stabilize blood sugar and support liver function, specifically choline-rich foods, particularly whole eggs. Choline is a nutrient with a specific and critical role in liver function. It is required for the liver to package and export fat as VLDL particles. Without adequate choline, fat accumulates inside liver cells rather than being transported out. Choline deficiency is one of the most under-recognized contributors to fatty liver in adults over 60, and the egg yolk is one of the richest dietary sources available. Decades of advice to avoid egg yolks has contributed to inadequate choline intake in exactly the population most vulnerable to this mechanism. Fatty fish, salmon, mackerel, sardines, 2 to 3 times per week. EPA and DHA from these fish have been shown in multiple studies to reduce liver triglycerides, reduce hepatic inflammation, and improve the metabolic environment the liver operates in. The mechanism involves both direct anti-inflammatory action and improvement in lipid metabolism within liver cells. Cruciferous vegetables, broccoli, cauliflower, kale, cabbage, mustard greens, consumed consistently. These contain sulforaphane and other compounds that support the liver's detoxification pathways and reduce oxidative stress in hepatic tissue. They are not a dramatic intervention. They are a consistent contribution to the liver's maintenance capacity. Coffee, black or with a small amount of plain milk. This is one of the better supported findings in hepatology research. Regular coffee consumption is associated with lower liver enzyme levels, reduced fibrosis progression, and measurably lower risk of advancing from simple steatosis to steatohepatitis. The beneficial compounds are present in the coffee itself, not in the sugar syrups, flavored creamers, or sweetened versions that accompany most commercial coffee drinks. Adequate dietary fiber from vegetables, legumes, whole fruits, oats, and barley. Fiber feeds the beneficial bacteria in the gut, which produce short-chain fatty acids that reduce liver inflammation and improve insulin sensitivity. The gut-liver connection is direct and well documented. What happens in the intestine affects what the liver receives and has to process. A diet consistently low in fiber is a diet that is consistently disadvantaging the liver. Skeletal muscle is the largest site of glucose disposal in the body. When muscle is active, it absorbs glucose directly from the bloodstream, reducing the amount that reaches the liver, reducing the insulin demand, and directly reducing the substrate available for de novo lipogenesis. This is why physical activity has a documented, specific, mechanistic effect on liver fat, independent of weight loss. Studies have shown that regular moderate exercise reduces liver fat even when body weight does not change significantly, because the reduction in glucose flux through the liver matters independently of caloric balance. A 30-minute walk each day changes the metabolic load on the liver. This is not motivational language. It is the direct consequence of activating the body's largest glucose disposal system. Adding brief periods of higher intensity movement, short bursts of faster walking, stair climbing, or resistance exercises for the large leg muscles amplifies this effect substantially. The legs, quadriceps, and gluteal muscles are among the most metabolically significant tissues for blood sugar management. Poor sleep elevates cortisol. Elevated cortisol raises blood sugar. Elevated blood sugar increases insulin demand. Increased insulin drives fat production in the liver. The pathway from inadequate sleep to accelerated fatty liver progression is not theoretical. It is a documented hormonal and metabolic cascade. Additionally, poor sleep impairs the judgment and energy levels that make dietary choices more difficult throughout the following day. The compounding effect of chronic poor sleep on metabolic health is substantially larger than most people appreciate. Sleep apnea deserves specific mention. Repeated overnight oxygen drops from apnea events produce oxidative stress in the liver specifically. Hepatocytes are vulnerable to hypoxia in ways that compound the inflammatory stress from metabolic dysfunction. Undiagnosed sleep apnea in someone with fatty liver is a significant additional driver of progression. If you snore heavily or wake unrefreshed despite adequate sleep duration, evaluation for sleep apnea is worth prioritizing. Beyond the standard ultrasound follow-up, 5 specific things worth requesting from your healthcare provider. ALT and AST enzyme levels at every follow-up. These liver enzymes reflect whether inflammation is present and whether it is changing over time. A stable grade 1 finding with normal liver enzymes is a different situation from grade 1 with elevated enzymes. Fasting insulin, not just fasting glucose. Fasting glucose can be normal, while fasting insulin is already significantly elevated, reflecting the early phase of insulin resistance before blood sugar becomes overtly abnormal. Fasting insulin is the earlier, more sensitive marker. Triglycerides and HDL cholesterol to assess whether the metabolic syndrome pattern is present, a fibroscan or liver elastography, if available, a non-invasive imaging test that assesses liver stiffness, which correlates with fibrosis. This provides information that standard ultrasound cannot. Vitamin D level. Vitamin D deficiency is significantly more common in people with NAFLD than in the general population, and is independently associated with more severe liver inflammation. It is a treatable gap that is frequently overlooked. Grade 1 fatty liver without significant inflammation is genuinely reversible. This is not empty reassurance. It reflects the liver's documented regenerative capacity. The timeline is not weeks from a detox protocol. It is months of consistent change in the metabolic conditions the liver is operating in. Research shows that reducing sweetened beverage consumption produces measurable reductions in liver fat within 4 to 8 weeks. Studies on weight reduction, even modest reductions of 7 to 10% of body weight, show significant improvements in liver fat content and liver enzyme levels over 3 to 6 months. Exercise interventions show measurable liver fat reduction within 8 to 12 weeks, even without weight loss. The most important principle: you are not working against your liver. You are working with an organ that is actively trying to repair itself whenever the pressure on it is reduced. Consistency of the right conditions over months produces the outcome that dramatic short-term interventions cannot. Fatty liver is a metabolic signal, not an isolated organ problem. It reflects insulin resistance, and the same process driving it is driving the elevated triglycerides, low HDL, central fat accumulation, and borderline blood sugar that frequently accompany it. The liver stays silent even as this progresses, which is why a mild early result is exactly the time to act. Not because the situation is urgent, but because the regenerative window is open. The 3 changes have the most direct documented effect on liver fat: reducing liquid fructose and refined carbohydrates, adding regular physical movement that activates large muscle groups, and ensuring adequate choline, fiber, and omega-3 intake through food. Your liver has remarkable capacity to recover. What it needs from you is a sustained change in the metabolic conditions it is operating in, not a 2-week detox, not a single eliminated food, but a consistent shift in the daily pattern that created the pressure in the first place. If this gives you a clearer picture of what a fatty liver result actually means and what moves the needle on reversing it, rather than just being told to watch your diet, please share it with someone who received the same result and deserves the same clarity. Subscribe for more evidence-based health content designed specifically for adults over 60. We will see you in the next one.